various publications of the surgical group in which they have defined and created a nomenclature that has been largely mapped with the the IPCCC nomenclature. So you'll see definitions from time to time. This is a very erudite one. It is simply a hole in the interventricular septum, so that's not too surprising. The physiology in which this results, of course, is a left to right shunt at ventricular level. There's a hole here between the ventricles of variable size, and so a variable amount of blood going from the higher pressure left ventricle into the lower pressure right ventricle. And the amount of blood that passes here depends largely on the size of the defect. Obviously, a bigger defect permits more blood to flow, and on the pressure difference between the ventricles. If there is, for some reason, high pressure in the right ventricle, not very much blood goes. If the pressure difference is relatively large, then a lot of blood can go. And so this results in excessive pulmonary blood flow, a left to right shunt, excessive pulmonary blood flow, higher saturation here, volume work for the left ventricle because the left ventricle has to pump not only the blood going to the body, but also the extra blood that goes across the ventricular septal defect. And there may also be variable hypertension in the right ventricle and pulmonary artery, depending on largely how big the defect is, given that the lungs are otherwise normal. The larger the defect, obviously, the better pressure is transmitted from the high pressure left ventricle, and the higher the pressure becomes in the right ventricle and the pulmonary artery in the absence of any pulmonary stenosis. So the size of the defect, obviously, is a very important factor in determining the physiology here and what happens to patients like this. Now, if we just take a very schematic view of the interventricular septum, we're looking at it from the right ventricle with the free wall removed. And so we can see the septal leaflet of the tricuspid valve here, most of the interventricular septum looked at on FOSS, and a few of the landmarks that we use in the right ventricle to look at the interventricular septum. One is the septal band, which forms a little muscle band on the septum from which the moderator band, which then goes to the free wall, arises. The septal band divides into a superior ramus and an inferior ramus. The papillary muscle of the conus is attached to the inferior ramus, and the infundibular septum or outlet septum or outflow septum inserts in between the limbs of the septal band and closes the interventricular foramen. So given this, we can think about where defects are likely to occur in the interventricular septum. And that depends a lot on the embryology, because the septum is formed of basically 4 structures. The part down here, most of the muscular septum, is formed as the 2 chambers, the left ventricle and right ventricle, balloon out of the primitive heart tube. They balloon out of the greater curvature, and as they do so, the heart tube itself doesn't really grow much, so the interventricular foramen remains relatively fixed. And as the chambers balloon out on either side of that, the septum develops in between. And it forms largely by coalescence of tuberculations of muscle plates that develop out in this area. So you can imagine that you could have defects all over the place out here, and in fact, you do. You can see defects at many places in the muscular septum because these tuberculations sometimes don't coalesce and compact normally. You also can see defects at areas where different parts of the septum come together. There's another part of the septum that's the basal muscular septum. It's about the basal 1/3. I haven't quite drawn it accurately here, but it's about the basal 1/3 of the ventricular septum. It's what's missing when we have a complete common Av canal defect. It isn't clear where this part of the interventricular septum comes from. It isn't completely understood how this is formed. But it forms around the time that the Av canal is dividing and that the endocardial cushions are making the atrioventricular valves. And then there's the membranous septum, which is the very top part of this, which comes from the AV cushions. It clearly forms as the cushions divide and sort of drape themselves over the rest of the muscular septum here, and that forms. And then the outlet septum forms from the ridges or the cushions that form in the outflow tract that divide the entire outflow tract and give rise to the semilunar valves. So all of these things have to come together and mesh and join each other, and if they don't, then we get ventricular septal defects. So you can have defects back here in the inlet muscular septum. You can have defects around the membranous septum where it joins the rest of the muscular septum. You can have defects where the outlet septum normally joins the rest of the muscular septum. So if you think about it that way, it becomes obvious why defects occur at different and specific points inside the heart. Here's an example of the first type that we talked about, which is the Av Canal type defect. Here we see the inlet of the right ventricle down here. Here's the tricuspid valve, the septal leaflet, and you can see there's a very large defect here behind the septal leaflet of the tricuspid valve. The papillary muscle of the conus is right up here, marking the inferior ramus of septal band. The superior ramus is up here, and this is the septal band over here. There's the papillary muscle of the conus. And this is the infundibular septum and parietal band going out in this direction. The pulmonary valve is right up here. So this is a basal inlet type of ventricular septal defect. And if we look at this now from the left ventricular side, you see that the septum that's missing, and we'll see this later when we see common Av canal defects, is what's missing in this. It goes all the way to the tricuspid valve annulus. This is tricuspid valve. This is mitral valve. It goes all the way to the annulus of the tricuspid valve and can be quite large, as you can see in this case. And it extends down to the usually close to the diaphragmatic surface of the heart. And there's the aortic valve up here and the outflow of the left ventricle. So you can see right through to the right ventricle here because of this large ventricular septal defect. Now, if we look at a membranous defect, it occurs around the membranous septum. What's going on here? Yeah. So the membranous septum is just below the commissure between the septal and the anterior leaflet of the tricuspid valve. So here's the septal leaflet right here onto the septum. The commissure is about here, and this is the anterior leaflet up here. So a membranous defect would be right there. If we look up in the outlet septum, here's the pulmonary valve, here's septal band, here's the papillary muscle of the conus here, inferior ramus, superior ramus. All of this is intact. The membranous septum is right here below, right there, just at the commissure between the septal and anterior leaflets. From the left ventricular side, here we see the aortic leaflets. This is the right and the non-coronary leaflets. The non is in continuity with the mitral valve. The right is here. And you can see the defect is here just below the commissure between the right and non-coronary leaflets. That's where the membranous septum typically is. So from the left ventricular side, you can see the defect as well. We'll skip that one. And go on to a conoventricular defect. This is between the conal or infundibular septum and the rest of the septum. Remember, we said it forms from the outflow ridges, and if they don't connect normally with the rest of the septum, then we have this defect. Here's the septal band, superior, inferior ramus, and here's the defect between the limbs. Here's the papillary muscle of the conus, the inferior ramus of septal band, and you can see the pulmonary valve leaflets come right down to the defect. And there's the defect there between the limbs of septal band. If we look from the left ventricular side, there's pulmonary leaflets. Here's the infundibular septum. In this case, it's very thin and fibrous, as it often is when it's displaced backwards. This is the aortic valve here, aortic to mitral continuity. And this is a posterior displacement of the infundibular septum, a conal ventricular defect with posterior displacement. We see this in interrupted aortic arch, coarctation, that sort of thing. So you can see the pulmonary valve leaflets here above the defect. Here's the very small infundibular septum, and then the aortic valve leaflets on the other side. We can also have a conal septal problem where the infundibular or conal septum is simply missing. And that's the situation here. We're looking again from the right side. Here's the tricuspid valve, the septal leaflet. The papillary muscle of the conus is up here. Here's the anterior leaflet, inferior leaflet. And here's the wide septal band, the superior ramus and the inferior ramus. And the septal band continues down this way. And here's the defect in between. There's papillary muscle of the conus. And notice that when we cone in on this, you can see aortic valve leaflets through the defect there from the other side. And these are the pulmonary valve leaflets here from the right side. And there's nothing in between them. You go directly from pulmonary to aortic leaflet with no infundibular septum at all. So it's completely absent in this. This is also known as a subpulmonary or doubly committed subarterial defect. It has a lot of names, or a conal septal defect in the sense that the conal septum is missing. And here we see it from the left ventricular side. Here's the aortic leaflet. The pulmonary valve leaflet is just over here on the other side, and here's the defect. Muscular defects can occur in a number of places. They often occur between the basal third and apical third of the interventricular septum. Sometimes they occur in this area. Here you can see this is the septum that was formed by outward ballooning of the ventricles, and this is the basal third of the septum, and there's a big defect here between the two. The outlet septum, the outflow of the heart are all normal in this case. There's another anterior defect up here as well. From the left ventricular side, you can see the big defect. There's a muscle bundle back here before we get to the aortic valve. The membranous septum is here at the commissure between the right and non-coronary leaflets. This is between the apical 2/3 and the basal 1/3 of the interventricular septum. And you can have other mid-muscular type defects like this as well. So management of these largely is medical to begin with, because many of these defects will close. So we'd like to give the patient the opportunity to do that. And we typically use diuretics. Some people use vasodilators. Some people use digoxin. And then for patients who fail to thrive despite medical therapy, or have significant pulmonary hypertension that's concerning, or have persistent LV dilatation, evidence of a big volume load on the ventricle, these are typically considered indications for surgical, or in some cases, device closure of the defect. You up?
Just to let you know that there's a videographer in the back who's recording everything we say, and this will be available on the website for you and used in evidence against me.
Okay, so you don't have to worry if there's something you missed. You can play it again and again and again if you feel that way about it. Karen, you're not doing anything in this session? Okay. Okay. Well, from the echocardiographic point of view, what we want to do, we want to identify all of the defects in the ventricular septum, and I think we have to think that there are more than one. Parenthetically, I just want to say that it depends on how you look at incidence studies for VSDs, but VSDs make up between 40 at the lower end, simply primary VSDs, and 80% of all congenital heart disease. And yet, if you look at the number of publications in the literature about VSDs, which is the commonest lesion, it's very rare that you will find a new and exciting study on VSDs. So you have to identify all the defects in the ventricular septum. You have to assess the chamber size, as Dr. Sanders mentioned, the volume load, as well as the volume. Yes, oh, I don't know why that happened. Let me just take care of that quickly. Thank you very much. Thanks very much, Girish. That looks better, doesn't it? Thank you.
It's not showing up here.
I know it wasn't showing up there when you were talking either. I don't know why.
You didn't tell me.
I don't like to irritate you. I wish you'd do the same for me. All right, so assess the size, and as Dr. Sanders had mentioned, you know, you have to look not only the volume load on the left side of the heart, but the pressure load, and the right ventricle is not as less important than the left ventricle in making an assessment about VSDs. We have to estimate the pulmonary arterial and right-sided pressures, and we can do that for a variety of means, largely looking at interventricular gradients, tricuspid regurgitation, and pulmonary regurgitation velocities. We have to identify if there are additional defects, which there frequently are. Quantify the magnitude of the shunt, which we can actually do echocardiographically rather well, and then we have to image the VSDs. Now, because two-dimensional echocardiography has limitation, we have to use multiple planar approach to look at the VSDs, and until we get the perfect 3D all over, we're going to be using this technique a lot. And by getting fixed from multiple planes, we can get a better idea of the size of the ventricular septal defect. And what has become for us a standard is the use of Doppler color flow modality for helping us, particularly with small apical muscular VSDs. Now, I don't want to say too much about it. There, as Steve said, the best way to describe a VSD is as a hole between the two ventricular chambers. And they occur in many places. What I'm going to concentrate on is, in terms of membranous VSDs, is to know where the conducting tissue is running, because I think it's very important for us to tell our surgical colleagues, for those of us that do that, where the ventricular septal defect is running, so that they don't put stitches in it when they are trying to repair it. And in fact, the first series of congenital heart disease, heart block patients, all came from Minnesota, which is why Medtronic company comes from Minneapolis, because Dr. C. Walton Lillyhigh didn't know anything about the conducting tissue and where it's running. So I think this is one of the important services we do for the surgeons. So I'll start off with what is a common form of closure, and this is the aneurysm of the membranous septum. You see the ventricular septal defect. It's walled off here, as you see it in these cross-sectional views, by tricuspid tissue. Here's a 70-year-old man with calcific aortic stenosis. Let me get out of the way here, otherwise you can't see. I'll just put my computer on top of yours. No, don't worry, I'm fine. Sorry, Girish. How about that? So this is a 70-year-old man with calcific aortic stenosis who had a VSD that's entirely closed now. You can see the tendinous cords of the tricuspid valve on the other side of the VSD. And this is a common means of ventricular septal defect closure. Here you see it here. Here you see VSD in the membranous septum. It's immediately subaortic in its relationship. And we can also measure the velocity coming across this. This is a larger patient. He's obviously got a high arterial pressure, and he's got 126 millimeters of mercury estimated pressure difference between the left and the right ventricle. Here's the ventricular septal aneurysm by color flow, and you can see that how the tricuspid probably walls off this defect, and then the shunt comes in between the various parts of the defect. The surgeons have this habit of trying to repair these lesions. We have a motto in our hospital: no defect too small to close. And then we have this other thing where they will close it and they will leave a residual VSD, and that's an operation called making a small VSD into a smaller VSD. But I mean, you can't really control the surgeons. Okay, Frequently, you will see, even in a membranous ventricular septal defect, because of the chordae tendineae on the tricuspid valve, you'll see multiple shunts coming really from one VSD as we look at this in 3 dimensions as it billows out the septal leaflet of the tricuspid valve, under which almost all perimembranous VSDs lie. I'll put the labels on and I'll take the labels off again so that you'll get a chance to see them. Now we can even do this by transesophageal views, and here are 3 transesophageal views, a 4-chamber view, a long axis view, and a transgastric view. Many of these can be done after surgery as they are here, and there's no residual ventricular septal defect here, except in that patient. Whoops. So here's an example by pathology of 2 different mechanisms of closure of a ventricular septal defect. Above we see here the septal leaflet of the tricuspid valve, and in the hole you can also see endocardial tissue that's proliferated. And if you think that that's artificial, here is a patient at surgery which shows the same thing. Note the sucker, which is about 2 millimeters in diameter, virtually approaches the size of this hole, which led to my expression, no defect too small. And you see here the endothelial tissue with the tricuspid valve tissue walling this off as we do pathologically. And here is a 4-chamber view showing this aneurysmal bulge of the septal leaflet of the tricuspid valve caused by this lesion. There's also a chordae tendineae coming from the mitral valve, indicating a so-called cleft in the anterior leaflet of the mitral valve here. Muscular Vsds, as Steve said, this is, occurs in small children in up to 2% of normal children. So muscular Vsds in neonates are probably the commonest form of congenital heart disease we see. Okay, they have a very high incidence of spontaneous closure. We call this the golden echo in our laboratory, because you get one echo to prove that they're there, and then you do the second one to prove that they're gone, and that is 2 bills. So it's very useful to have them. But other than that, they give you some idea for the cause of murmurs, and you can see in the short axis here. Here's the specimen oriented in short axis with the VSD here. Here you see this proximal isovelocity surface acceleration with the border of the alias being over here. So that this is traveling at 64 centimeters per second here. This is the radius, it's a small shunt, and this is the shunt going into the right ventricle. And incidentally, for the neonatologist, this is the commonest reason for you finding a high-pitched murmur on the precordial area. And until we got color flow, this was the most uncommon way for us to actually recognize the holes, because without color you will not recognize this hole. And of course, muscular Vsds, as Steve said, can occur anywhere in the muscular septum. And you see here small VSD. You see 2 spreads of the jet in this 4-chamber view between the left and the right ventricle. Here you see in the short axis, there's a lesion here in the mid-muscular septum, and this typical small anterior muscular ventricular septal defect here. And in the long axis, so this is short axis and long axis, you can see the size of the hole as well. Again, a small defect, about 3 millimeters or less, with a high incidence of spontaneous closure. This is a patient who has the spongy myocardium, as you'll see by the arrows, and also the sponginess, which Steve pointed out so beautifully, is as the ventricle grows, if it's spongy, there can be lots of holes in the ventricular septum, and there are multiple ventricular septal defects here. Let's just play it there and put the color flow on, and you can see the huge trabeculations from the spongy myocardium, as well as a whole lot of Swiss cheese defects over here. This is one of the few patients in our institution that we elected to put a pulmonary arterial band on rather than close the VSDs, because the muscle doesn't allow you to put many bites in to close it, and you have to wait for these patients to mature their myocardium before you close their VSDs. This is a tragic example of a patient who was hit in a car from behind, fractured both his femurs, and the force of his chest hitting the seat caused him to have a traumatic ventricular septal defect. And you can see here in this short axis here, this is left ventricle, this is right ventricle by transesophageal, and you can see the inlet, the kind of explosion in the ventricular septum and the outlet of the ventricular septal defect there. Here you can see once again, this is all septum here. This is the right ventricular aspect of the septum, this is the left ventricular aspect of the septum, and a four-chamber aspect here. And this defect was closed in layers, as you can see it here, the left side of the defect and then the right side of the defect, and this was compressed, and he made actually an uneventful recovery. Now, how do we close VSDs? Here's an example of how you close a ventricular septal defect. For those of you who haven't seen this cartoon, here we go. This is, anybody can do this. You watch this once, and after that it's very easy to close the VSD. There's the wire coming through the aorta. Now they push the wire into the aorta, into the left ventricle, withdraw the catheter, put in another catheter with a J loop on it, put it up into the superior vena cava. This takes really 5 minutes. Then you put another wire up from below. We'll just straighten that up for you for a minute. Here comes the other loop here, and now they grab the loop to make a continuous loop all over, lassos the loop, pulls it down, and then pulls a wire through that goes all the way from the inferior vena cava to the descending aorta, as you see there. And now he withdraws the loop back here, and you'll see in a moment. Here comes the other catheter, which pushes the loop down into the left ventricle. When they get that down there, they put the loop there so they can put the wire in. Very simple. And here comes the other catheter across there. And now they take the wire out, and now they put the device in. It's this quick. And this is always done under echocardiographic control, so you can see it occurring. Pull the wire out for safety there, and now the device is coming, and Bob's your uncle. We close the ventricular septal defect. There, they put the device in, they've measured it correctly under echocardiographic control. And here comes this membranous device here, which is not in general use, but I think it gives you an example of how to close a ventricular septal defect. And then the second device comes across here, and there's the whole defect closed. This little dot tells you where to put it because the other limb is offset a little bit by it, and that's the end of that tune. So this is a muscular device, and here you can see the muscular device in the apex of the ventricle. It gets withdrawn across here. Then the other arm gets open here. You can see the wire off the back here, and then it gets released, and we put color in, and you can see that this lesion is completely closed with the exception of a little mitral regurg. Now with the value of instant replay, we get to see this again. The wire is removed, the two devices change their position a little bit. You can almost see a three-dimensional look of that. There is no residual leak, and the defect is closed. So this is a membranous defect, and you'll see this is Dr. Ziad Hijazi from Chicago placing a device in here. There's the VSD, it's perimembranous, and here comes the wire across the defect. He's doing this a little differently. I'll speed this up for you. He also uses angiography, and here he puts in the device, and he puts it in on both sides of this VSD. Here's the wire still in place now, checks that everything is okay. Here goes the one side of the device, and then he'll release the other one as well. Now that's released under X-ray control as well, and then the device is removed, and that's a small membranous VSD with an aneurysm, in fact, that has closed the defect. So I think enough of that. Now let's move on to the other defect that is quite common, the supraventricular or doubly committed subarterial VSD. Here's an autopsy picture showing the pulmonary valve and the aorta with no intervening muscle between it. And here you see the VSD with the pulmonary artery and the aorta in fibrous continuity with each other, and the VSD left to right shunt. This is a subcostal sagittal view. So this is front, back, top, and bottom. This is a long axis view. You see the VSD here. Here's the pulmonary artery. Here's the aorta. There's no intervening muscular septum. Short axis showing the device over a little bit, little pulmonary insufficiency, and the VSD underneath the two lesions shunting from left to right. Now, one of the things that always seems to puzzle people is why, if these lesions are situated around the septal leaf, the right coronary cusp of the aorta, here's where the membranous septal defects occur. Here's where the doubly committed subarterial VSDs occur in this direction. And you can see here is a membranous VSD, which is shunting at this point in short axis, and at this point over here in short axis as well. And here are the two defects in pathologically. You see the front defect here is the supracrystal, the back defect is the aortic, because actually the specimen, although it looks like a short axis, is taken on a different alignment. So perimembranous VSD shunt here at about 10 o'clock, and doubly committed subarterial VSDs shunt at about 2 o'clock when you look at them in the short axis view. One of the problems with this lesion is because the right coronary cusp has no support, it tends to prolapse through, and then what happens to the murmur is the murmur diminishes until you get the murmur of aortic insufficiency, as you see over here, and that's one of the reasons why this lesion has a high rate of surgical closure, because the prolapse occurs before the aortic insufficiency, and it's much easier to fix a VSD than it is to fix aortic insufficiency effectively. This is the posterior malalignment or conoventricular defect that Dr. Sanders mentioned. I'm really disappointed that Steve didn't mention the great line of Dr. Richard van Praag, that in interrupted aortic arch and cooptation, all the woe lies below. Woe is trouble. So all the woe lies below means that, this is where really the problem with this lesion is, not with the interrupted arch or the cooptation. And here's this posterior alignment here. Now when you fix this VSD only, then you get ready to develop subaortic stenosis, and sometimes you have to accept a little subaortic stenosis without a shunt, because you decrease the volume of flow there, and you may get away with it, allow a little growth, and then come back later and fix this through the aortic valve, because you can't fix this in any other way. So here we see long axis views, and here's a short axis view, and you see this posterior malalignment. Here's pulmonary artery, here's tricuspid valve, here's the membranous septum, and there's a posterior malalignment of the outlet septum. Okay. Now, sometimes VSDs are very big, and this is a patient who was discovered to have a monstrous ventricular septal defect at 14 years of age and has pulmonary vascular disease. And when you give salt water injection into the right side of the heart, you see it fills the left side almost completely. I beg your pardon. Yeah, when you give it on the right side of the heart, it fills both these structures. This patient had pulmonary vascular disease and eventually was just treated with pulmonary hypertension, was too late for surgical closure. Okay, inlet VSDs of the Av Canal type. Steve didn't make any point about this, but in my experience, this lesion occurs almost exclusively in patients with Down syndrome, and in fact may be a form thrust of, he's not agreeing with me, but that's okay. But it's a form thrust of an Av Canal defect, and often there is a cleft mitral valve with this condition, and here you see the isolated cleft in the subcostal view of a cleft mitral valve. This is pulmonary artery. Here's the VSD. The VSD chordae always go to the cleft in the valve. Okay, and here it is situated posteriorly, as you'd expect with the shunt, really posterior, just proximal to the coronary sinus area. And here once again you see the tendinous cords. You see the left component of this atrioventricular valve is in fact a tricuspid leaflet with the mural leaflet the posterior inferior bridging and the anterior superior bridging part of the leaflet very well displayed in that example there. Now, how do we assess the size of the VSD? Well, we look also to see what the pressure is. And if, to my mind, if the pressure is anything above 3 meters per second, that suggests that the VSD is restrictive. I think under 3 meters per second, it's not easy to say that it's restrictive because you don't know what's happening with the flow on the left side of the septum. Okay? And of course, it may be, when it's small, may be variable. Here is a systolic left to right shunt, a very small one, and then a diastolic left to right shunt as well. So VSDs can shunt not only in systole, but they can shunt in diastole as well. We can measure tricuspid regurgitation. In this patient, there was substantial tricuspid regurgitation with a pressure predicted to be 65 millimeters of mercury in the right ventricle, and with the pulmonary arterial diastolic pressure being a mean of 76 millimeters of mercury here. So this is a patient, on these two picked examples, of a patient who had probably pulmonary hypertension on the basis of ventricular septal defect, and obviously a larger patient with real crisis and need for cardiac catheterization. Okay? That just once again highlights looking at the VSD jet, and here's a very small ventricular septal defect with a little puff, and what you hear with the stethoscope is a little tss, 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 with this very high-pitched murmur, high velocity, and with the low pressures in the pulmonary circulation. And I mentioned how to calculate the QPQS. We calculate it from a cross-sectional area of the vessel, and I've used a down and dirty because the area of the velocity or velocity time integral from this that I showed you earlier on is the base times the height over 2, and as the difference between the base over 2 is very small, you can relate the ratios, again ratios, of the height of the pulmonary signal to the height of the aortic signal, and multiply that by the squares of the difference of the diameter between the aorta and the pulmonary artery. And here's the formula, which you'll be able to see on video, which gives you an example of how to calculate the flows. Thank you.
Norm, while Girish is setting up, can I ask you a question? Do you think you can estimate right ventricular pressures by the gradient across the VSD? So not the restriction of the VSD, but the right ventricular pressure.
It's very difficult sometimes, especially as when it gets small, I think it gets so restrictive that you can't use the Bernoulli equation. The Bernoulli equation is, you know, I mean, it's not cast in stone that you can use it.
Well, I'm asking because we don't, because Jeff Smallhorn previously now they have established that the contraction of the left and right ventricles aren't at the same time.
That's true.
So while you can measure a gradient, you can't estimate an RV pressure. Well, Jeff, maybe you can just
I think it depends, you know, I mean, when it's high, I think you can tell that it's restrictive. But when it's under 3 meters per second, and that's my rule, if it's under 3 meters per second, I would not say that it's restrictive or not. Well, you can go as high as you like. I'm just giving you my numbers.
So at what level he will be concerned? What's the
Anything under 3 meters per second triggers me to look at further investigations for that. I mean, I practice mainly echocardiography. That's something I refer back to the clinicians, and let the clinicians make decisions based on that. But I would not say that if it's under 3 meters per second, I don't say that there's pressure restriction between the two ventricles. And I may be wrong, but my choice is always to err to the benefit of the patient. So I'd rather have a precaution so that the patient will get further investigation than fail on that patient and let the patient develop pulmonary vascular disease.
I think one of the things that that I was hoping Norm was going to talk about, that is a 2D related thing that I'm going to mention, is when you've got perimembranous or membranous ventricular septal defects, you have to make sure that the jet that you're getting a peak gradient on is actually a VSD jet or is actually a TR jet versus an LV to RA shunt kind of a jet. Because remembering the AV valve offset, you can have a small portion of VSD between the LV and the right atrium, a direct continuation, right, a Gerbode defect. And if you have that, then you're going to get a jet that is going to look very much like the location of a TR jet, unless you're careful. And if you get a gradient through there, it's going to be reflective of your blood pressure, which is going to make you think, oh my God, somebody's inoperable or they need a cath or something like that, and you might find out that they really don't. So you have to use multiple windows to figure out where different things are coming from, and so on. In general terms, I found that VSDs are much more reliable by way of gradients, and TR tends to lie a lot. TR tends to underestimate things a lot. Let me put it differently. It's very easy for us to underestimate TR gradients. All right. So I'm going to start out by showing you something I already showed you before, because this is, you know, with much of the stuff that that Norm is talking about, it's big picture, lots of things. With 3D, it's really a function of learning a different kind of language almost, a different kind of image, the way that the images look and things like that. So I'm going to start out by showing you how we look at the ventricular septum in the normal heart first, and then we'll go on to VSDs. So this is what I showed you earlier. It's an apical 4-chamber view looking at the ventricular septum, and what I'm going to do now is I'm going to cut away the free walls of the heart, and I'm just going to look at the septal structure. And the reason for doing this is going to become clear as we move further through the data sets. So now we're looking from the left side to the right side. So this is the aortic valve up here. This would be the region of the sort of the membranous septum over here. Subarterial VSD would be over there, or and the mitral valve is over here, and so on. This is a full volume acquisition. This is what we are going to be using for looking at VSDs. This is looking at that same thing from the right side. So this is the septal leaflet of the tricuspid valve over there, and that's the subpulmonary conus. Pulmonary valve is going to be on that side over there. But basically, this is the RV aspect of the ventricular septum. Now, there are some things that 3D echo is not very good at. Thin parts of septal structures is one of them. Just like we talked about with ASDs, same thing. So I'm not going to try to show you a sort of classic small perimembranous VSD. It doesn't really work very well. You know, similarly, I don't try to diagnose new diagnosis of VSDs with this modality and so on. Okay, so now I'm going to start out by showing you a patient with, I'll show you two examples of muscular VSDs, because I think that's really where the modality kind of comes into its own, and then I'll show you a couple of other things as well. And both of these are slightly off-axis kind of acquisitions, and so they're going to make the whole idea of cropping these images a little bit more challenging, so bear with me. So there's your apical 4-chamber view, two-dimensional looking kind of a view, and if you look down here, you get a sense for the fact that that things are not continuous. You see that? So what I'm doing now is I'm taking this 3-dimensional image and I'm kind of simulating a 2-dimensional sweep from it. And as I do that, you're going to see a break right there. Right? Okay. Now the question is, what does that VSD really look like? You know, is it a circle? Is it a slit? What do we know about it? So I'm going to bring in this thing that's called a crop adjust plane. And what this allows you to do is it allows you to kind of cut the heart in different angles. So now I'm going to cut off the free wall, because, you know, if I try to cut this off straight from the sides, it would not work, because the septum is at an angle in this acquisition. You see, it's not a perfect acquisition. And then I'm going to bring this one again from this side and do the same thing. And I think it's important for you to just get a sense for what we are doing with these things, because this is how you're going to understand what 3D looks like. So now we're looking at this from the side, and it looks like something you cannot recognize at all. And now we're going to give back the front and the back of the heart, and you still can't see the VSD. And then as you turn up, you'll see it there. Right? So that's the VSD over there. And in the apical 4-chamber echo view, 2D echo view, we were cutting it from here to there. Now in this 3D view, you see it this way. And it's a very interesting hole because it shows you how even though the muscular septum is thick, the defects inside it can point in different places. So this one, you can see if you look at it from above, you can't even see it. You have to really look from below, from the apex. And then you kind of start to get an idea of where it is. You can turn the same heart around and look at it from the right side. These data sets are large. Norm was talking about this. This data set is about 25 megabytes. So that's why it takes my old computer a little bit of time to work on it. So now here I am looking at it from the right side, and when you look at it from the right side, you can see it as you tilt from above downwards. So it's a tunnel. It opens lower on the left side and higher up on the right side. So there's the VSD looking at it from above, from the RV. So this would be kind of the way the surgeon would see it going in through the tricuspid valve, if you will. So that's the first one. And then while we're on that same kind of logic, I'll show you another one with muscular VSD. So we found this modality to be very, very helpful, especially for patients who have a Swiss cheese septum or any concern about multiple muscular VSDs. So one of the big lessons with muscular VSDs is that if you see one, look for more, because chances are you're going to find them. Now the way we find them is with 2D echo and with color. That's how you find them. And remember, if you've got multiple VSDs, if you've got a concern about high RV pressure with a high TR gradient or low gradient across your VSD, drop your scale when you do your sweeps, because otherwise you're going to miss multiple muscular VSDs. And that's a bad thing to find out post-operatively. So here's an example of something. And in this one, what we'll do is we'll just cut the sides off here. So we'll cut this side off, and then we'll cut off the other side. See, I couldn't do that with the other one because it was just angled too badly. And then we'll do the same thing again. I'm going to give back the front and the back, and you see a larger defect. This was a pretty substantial defect. And to be honest with you, this was one that our surgeon could not close completely the first time they went in. And then they ended up coming back. We did this imaging, kind of showed exactly where it was, and then the second attempt was quite successful. But this is very useful because even if this were a consideration for device closure, for example, of a muscular VSD, then the interventionalists are going to want to know where is it relative to the, is there a rim to the back? Because the device still has to fit. So where the septum ends in the back is and this one I would make the argument, Dr. Hijazi would probably disagree with me, but I would make the argument that this one goes very far back, this hole, to the posterior interventricular groove. The next one that I wanted to show you, this is a complex malformation, and I'm not really going too much into the detail of what all this patient had. But just to show you, not that we can show this every time, but it was just a beautiful example of tricuspid valve looking. We've cut away the roof of the right atrium, and we're looking down, right atrium, tricuspid valve, papillary muscle of the conus attaching over there, you see. And this is the great artery coming off. This was the aorta in this patient, and this is a muscle ridge below the aortic valve. So there was tricuspid to aortic continuity, and yet there was this muscle ridge that came across. All of this was verified by the surgeon. And you can see the VSD here sort of divided into two parts right there. See, there. So the papillary muscle of the conus goes and sits inside the Y of the septal band, and it divides this. This is a conoventricular VSD, malalignment VSD. So it basically sort of splits it into one component there and another component there. And you can also look at this from the LV side. So that's what it looks like from inside the cavity of the LV, that same hole. All right. The next thing I wanted to show you was a complete canal or a AV septal defect. Call it whatever you want. And this one, once again, what we found is for showing the septal structures, the 3D cropping sort of mechanisms are actually incredibly simple. And it's very important to keep things simple. So what I found was the more complicated we made the cropping, the harder it was for people to do it. So then we weren't doing it. So if you try to line up your septum straight up and down in your acquisition, it's very, very helpful, because then people can do manipulations on the fly. And these things that I'm showing you here, the manipulations can be done on an echo machine. You don't have to wait for fancy software to do them. So what I encourage my sonographers to do is to do the manipulations on the machine and save 3D clip, so that it will go in as an AVI that will go into your echo pack system. It does not matter what vendor echo pack system you have. It doesn't matter what vendor 3D echo you use. You'll be able to watch that image on your screen. So this is a patient with a canal. It's pretty obvious they have a canal, and it's a large hole. There's no question about this. So what could we learn about the anatomy here? I think we'll do the same thing, and I'm going to do this just a matter of principle, not that we're going to see something great or different here, but really to kind of lay the groundwork, I think, for what we see in terms of anatomy with 3D compared to 2D imaging. So now we're looking from the right side to the left side. This is the inferior and superior bridging leaflets, and this is the canal VSD. All of this is canal VSD. This is the crest of the ventricular septum. So by 2D echo, when you're in an apical 4-chamber view and you cut this VSD and you make measurements of it, you're going to be reporting measurements that are in these dimensions. And when Dr. Sanders shows specimens of these, you can see how this is exactly what you see, except here now with hearts moving on top of it. So you see the defects are really very irregular. And with the canal, it's classic. The septum is scooped out. And so the VSD is going to be deep, superior inferiorly in the middle, but it is going to be longest from front to back, at the base. So that's the general idea with this defect. And then there you see it from the left side. I think that's, I'm going to stop there. Questions with this?
Just while you're sitting up, I think that it's very interesting to look at the now concept that even the developers of the devices, that they think that, I've also noticed this kind of cigar shape or semi-lunar shape of the muscular VSD. And yet, when you look at the unplugged device, for example, the muscular device, it's a round device. And you can understand how when they put that device in place, that it goes in place perfectly, but there's still a VSD next to it. Then you have to go and put in a whole series of these things, even though it's one defect, in fact. And then the tragedy about looking at those is that you close them like that, and then what you actually have is you have other VSDs as well. So you close the one and then the little ones will show. So it's a real problem, but I think you highlighted that very beautifully. And I think also the other point that I would make about it in favor of 3D is that when you look at a VSD like that in the 4-chamber view or any other view, and you see a VSD in which you make one-dimension measurement on it, and you say this is really a small VSD, but you can't understand why the patient has got symptoms. Exactly. The patient's got symptoms because it is a small VSD in one dimension, but not in terms of the cross-sectional area, so the patient would be sick. you know, with a big left to right shunt,
Yeah.
albeit that it looks very small on 2D.
And the other side of this is that, you know, the understanding not everybody has 3D equipment and all. I think you can get the same information with multiple 2D sweeps.
Yes.
Absolutely. The advantage of this is that you can see it all in one picture. That's really
Show it to somebody else.
Show it to somebody else. Show it to the surgeon. Show it to the interventionist. The concept about the devices, you know, one of the things that I really firmly believe is, yeah, we've had great results with devices and it's all great, but I think it's really just the beginning. Because I think that these, you know, the waste of the device is still a pretty firm waste. You know, it's not a malleable waste, which is what you really need. I mean, you need something that's going to go up almost like filling air to a
Something
balloon.
almost like the
Fill up a gas.
PFO device, where there's a thin thing and the two arms and the left ventricular pressure will hold the device on the left side of the septum and sleep.
Yeah. So it's going to have to do all of that, and it's going to have to be easily seen by echo for us to be happy with it.
Just a caution on Norman talked about where the conduction system runs and devices in the perimembranous Vsds. Many centers in North America, I don't know about Europe, have stopped putting perimembranous devices in because it caused heart block in some patients because the conduction system runs along the crest of the VSD there, and perimembranous defects cause heart block in some patients. The other comment I just wanted to make about assessment of right ventricular pressures in VSDs, which I started asking about, because it's problematic, I think it's even more problematic in that Irish talked about LV to RA shunts, but even the jet of the VSD flow through the VSD contaminates your TR signal, and it's quite difficult actually to estimate pressure. So, you know, you have to be very careful of that. It's very tempting to measure that and say you've got to look at your septal configuration to as well see if it's flattened or not. And sometimes it's difficult to know.
And pulmonary regurg. I mean, I think the pulmonary regurg signal
right.
is not contaminated.
That's right. And
if you've got a low signal there, you probably
that's exactly right. In fact, we had a case this week before I came out here where it was the pulmonary regurgitant signal that confirmed for us that indeed there was elevated pulmonary vascular resistance because the TR jet was completely contaminated, or we weren't sure if it was VSD through the TR contaminating. So that's a good point. Okay, let's I'm not going to talk for too long on this, and I'm going to continue the concepts of this talk in the next talk on AVSD. But I talked about, in ASD, we talked about right ventricular volume loading. In VSD, we mainly talk about left ventricular volume loading, and one of the ways to judge if a shunt is clinically significant or not is to look at left chamber enlargement rather than formally calculate a QP to QS. And you can see the enlarged left atrium and left ventricle in this picture. Now, Ben Idem again, when tissue Doppler started being used, studied VSD as well as other conditions to see what happens. What was interesting to me, I don't quite understand why, and maybe others can comment, but left ventricular mass in the VSD patients was actually less than controls. Don't really know why that happened. But you can see that function in general, we consider function generally normal in VSDs. If you then use a small VSD versus a large VSD as a model of small versus large left ventricular loading, and you look at the E wave, which is the diastolic tissue velocity, or the S wave, which is the systolic tissue velocity, first of all, you see that there's not too much difference between in the small VSD versus controls. In the larger VSDs, you get mild differences. This, I think, is related to what I was talking to before, that you have an enlargement of your left ventricle. The ventricle doesn't need to displace as much to create the same stroke volume out of the aorta, but more than anything, I think this talks to chronic adaptation to the volume loading rather than an acute adaptation. If you look at the myocardial performance index, which Norman showed you before, a higher MPI is thought to be worse function, because you take from the isovolemic contraction, the isovolemic relaxation, adding them together over the ejection. So it's kind of the time that the ventricle is spent non-ejecting versus ejecting as an efficiency ratio, if you will. You can see that the MPI isn't too different either. between the two. Now remember, and I'm just going to use this to say in volume loading, when we look, and this is again from Bart Beingens, if you look at mitral velocities, so if you look at the usual E and A wave of your mitral inflow, these reflect changes, or they reflect the pressure gradient between the left atrium and the left ventricle. Okay, so your mitral flow, your E wave, reflects the pressure gradient between your atrium and your ventricle. The tissue Doppler more reflects the volume change. So when you're looking at your mitral, you're looking at your pressure gradient. When you're looking at your tissue Doppler, you're looking at a volume and at a stroke volume difference. So that is why E to E prime can get at filling pressures, and that's the difference. They're not the same thing, and they should be used differently. So when you see an elevation in VSDs, and if I don't want to go back, but if you saw in those tables, the E wave increased. The E prime didn't increase that much because of that adaptation. On a completely different subject, here is a paper that looked at the effect of VSD closure on recovery in the ICU. We know we have extremely good outcome rates for these patients, but nonetheless they spend some time in the ICU. I thought this was just a different paper to bring along. First of all, you can see we've talked about ASDs, we're going to talk about AVSDs, and now we're talking about VSDs. You can see that in terms of ventilation times or time in the PICU, you can see the grading between these lesions. They measured troponins as a measure of myocardial injury, if you will, and actually, surprisingly, the VSD and ASD were similar. You can see in AVSD the troponin levels were much higher. I don't know exactly what that means, but I think it's just a general measure, if you will. Now, if you look at, first of all, the parameters, there were a few surprising things in this paper to me, which I don't know, I'm just bringing up for discussion. But if you look preoperative at your LV tissue Doppler versus these are controls and patients. First of all, in general, what I wanted to say is RV velocities are much higher than LV velocities. That's normal. But if you look versus the VSD, you have lower preoperative tissue Doppler, which is different, and these are adult patients. You also have much lower RV velocities than your controls. So I thought, well, that may be the volume loading, but if you look at the isovolemic acceleration, which we said was a more load-independent measure, it's also much lower in these patients, although you're never going to have an isovolemic period when you have a VSD, right? Because as soon as the ventricle contracts, you've got blood changing from the ventricle. Whether this explains this quite profound difference in results, I don't know. But nevertheless, this paper was mainly interested, as I said, in the PICU changes. Here's LV, septum, and RV. And again, just like we saw for ASDs, there's a decrease in velocities and then a partial recovery, if you will, in velocities. And that's for the LV. If I go on, what was interesting about this paper is they correlated velocities. And look at this. This was RV, and we're still talking about VSD closures. They correlated the velocities. It's weak, but it's there, between the troponin levels and the RV velocities. And in fact, the velocities correlated, velocities, both systolic and the LV, correlated with ventilation time. And again, I was a little bit surprised by this, because if you're going to look at one echo measure and then predict such a general thing as ventilation time, which here is a marker of recovery, you're asking quite a tough job to do. So that's why I brought this slide. Again, just to quote from the same paper from Michael Chung, I showed you looking at force-frequency relationships in these lesions. Here you pace the patient, increasing the heart rate, and then you look at the isovolemic acceleration, and you expect to get a curve like that. You don't get the perfect curves. In ASD, there was no change from pre to post-op. Look at the difference in VSDs. Here's pre-op, a pretty normal force-frequency relationship. Post-op, these patients do have myocardial dysfunction. They aren't able to mount a normal force-frequency response, and that's why they may need inotropic support, etc. Now, how much time do we have? Am I running way over? Or I haven't spoken for much, but I can give up on this. Anyway, while Norman's looking, just briefly, this has nothing to do with tissue velocities
or strain. This was work done from Thomas Moller, who spent a year in Toronto now, but he comes from Norway, and Henrik Bruun last year was in Toronto, and they did this work in Norway, and they're interested in exercise echo. So we look at a lot of things at rest, but in fact when you provoke the patient and you need to have the heart function, that's when you unmask abnormalities. So in this paper, they took VSD, patients after VSD closure and ASD closure, and you can see, and here's right ventricular pressure, and here's the increasing workload, and you can see that there's some patients that have a low right ventricular systolic pressure after exercise, and there's some patients who elevate their right ventricular systolic pressures during exercise. And then if you take the groups, open VSD, closed VSD, and closed ASD, you actually see the group that has the worst elevation in right ventricular systolic pressures are actually those with the closed VSDs. So we as pediatric cardiologists often consider these patients as cured almost. We follow them and we say we've closed the defect, there's nothing wrong. But if you look at it, there are things during exercise which are abnormal, and this also affects their displacement. So Norman has asked me to give up on the rest of this talk. I don't have much more, but just to say that I think that there are long-term follow-up issues with function that we just need to be cognizant of in some patients. Thank you. You can clap for me, it's fine. Okay. Karen, are you up? No?
I can show 2 images of a VSD, but I can show them in other talks as well.
Well, then I think I want to push on with the AV septal defects. We have to be finished. We've got 45 minutes for the AV septal defects, right? So let's try and do that before lunch.
Don't put it on top of mine because I can't switch mine off and on easily.
So the types of defects that we're going to talk about under AV canal type defects, or AV septal defects if you want, include ASD primum or partial AV canal, a transitional type of AV canal where there is a ventricular septal defect and usually it's relatively small, and then complete common AV canal where there's typically a large ventricular septal defect. So again, what we have typically is a left to right shunt both at atrial level and at ventricular level in these patients. So in this case, there tends to be a biventricular volume overload. We see both ventricles more involved than often we see in ventricular septal defects, in part because of the atrial level shunt, and in part because the ventricular septal defect sometimes is so large that these ventricles sort of function in unison. There's also variable pulmonary hypertension. In ASD primum, it's quite uncommon to see pulmonary hypertension. It can happen, but it's uncommon. Also in transitional AV canals where the VSD is small, it's unlikely to see pulmonary hypertension. But in complete common AV canal, there's almost always pulmonary hypertension. In fact, that may be a prominent part of the clinical syndrome that we see in AV canal defects. These patients often have hyperinflation of their lungs because of the big left to right shunt. The small blood vessels in their lungs compress bronchi. They have air trapping like asthmatics. And so you see big expanded chests on chest x-ray quite commonly with this. There's also the problem that the AV valve is quite abnormal. It's in common mostly. And because of that, the function of the AV valve may not be normal. There may be more or less AV valve regurgitation in these patients, and that contributes even more to the volume load that we see on the ventricle. So these patients have a lot of reasons to have a sick ventricle and to have ventricular, or to have symptoms of heart failure, even though their ventricles usually appear to function pretty well. So back to our surgical definitions of this. The definition that's been presented of an ASD primum or partial AV canal is an AV canal defect with an ostium primum atrial communication usually a crescent-shaped ASD in the inferior posterior portion of the atrial septum just above the AV valve, and varying degrees of malformation of the left AV valve, actually both AV valves, leading to varying degrees, particularly of left AV valve regurgitation, with no ventricular septal defect being present. Now that doesn't mean there isn't deficiency of the interventricular septum, by the way. There's almost the same amount of deficiency in an ASD primum as there is in a common AV canal. The difference, as we'll see, is the insertions of the AV valves onto the crest of the interventricular septum. So here we're looking from the right side into the opened right heart here. This is the atrium, the ventricle. Here's the fossa area here. The appendage, superior vena cava are up here. This is the primum atrial septal defect here. Here's the free edge of the interatrial septum that just ends above the level of the AV valve. Instead of continuing down and fusing with the AV cushions, it just ends up here, and so we have AV valve down here, a hole, and the interatrial septum above. So here you can see the fossa area, and it's intact in this case. There's no, and there's the superior vena cava here. This is appendage there. Here's coronary sinus down here. And here we see the AV, the right ventricle. Here's the inferior leaflet part, and the superior leaflet part are up here, and they continue over to form the lateral leaflet in this case. Here's the defect with the edge of the interatrial septum seen here. And this is the commissure between what would usually be the septal leaflet and the anterior leaflet of the valve. And there's a ton of AV valve tissue here that is attached onto the crest of the septum. And it's this that prevents the ventricular septal defect. Because the closure line of the VSD is at this level, at the level of the AV valve tissue. So if it's adherent onto the crest of the ventricular septum, there's no way to get blood across below the closure plane of the AV valve. From the left side, we see the scooped out part of the septum here, the missing part of the interventricular septum that we referred to before. Here's the superior leaflet or superior cushion component, and the inferior leaflet or inferior cushion component, and then the lateral leaflet or lateral cushion component of the mitral valve. This is the anterolateral papillary muscle up here that receives only the superior, and the inframedial papillary muscle here, which receives only the inferior leaflet. And this is the left ventricular outflow tract. And you can also see that the higher these attachments of the AV valve are into the outflow tract, the more likely there is to be subaortic stenosis. So a transitional AV canal then, by definition, is one that has two distinct AV valve orifices, that is down into the ventricles. The orifice of the valve into the atrium is always common in all of these. It has both an ASD just above and a VSD just below the plane of the atrioventricular valves. The valves in the intermediate form do form two separate orifices, but they remain abnormal, and the VSD is often restrictive. And it depends in large part on the density of the attachments of the AV valve onto the crest of the septum. I think this is an example of that. This is a fairly small heart. So here we see the foramen ovale here. Here you can see septum primum and septum secundum. So there is, in fact, a communication there. This is the ASD primum. Down here, the free edge of the septum. This is the rest of the right atrium. Superior vena cava would be up here. This is all the appendage over here, and there's the coronary sinus back here in the corner. And again, this is the interatrial communication at that point. From the ventricles here, we see the right, the superior leaflet here. There's some ventricular septal defect back behind it. Here you can see it has pretty dense attachments here onto the septum. We'll see it better from the other side. As we turn to the left, here you can see the attachments of the AV valve onto the septum, and notice that there are little intercordal spaces, little spaces in between here, and it's through those that we can see interventricular communication, because and up here as well. You can see the closure plane is going to be here, and so there may be a little bit of opportunity below the closure plane of the AV valve for a ventricular septal defect. The lateral leaflet is seen over here. So finally, a complete common AV canal is an AV canal defect with both an atrial septal defect just above the AV valves and a non-restrictive defect of the ventricular septum just below the plane of the AV valves. The AV valve is one valve that bridges both ventricles, bridges across the ventricular septum, often without much in the way of attachments to attach into both. Now here we see a type A canal of the Rheology classification. Here's the superior leaflet here, and you can see the attachments there. The inferior leaflet is down here, and notice the sparseness of the attachments. There's a lot of space here, so we can get a large ventricular septal defect. This is the superior leaflet. The inferior leaflet is down here, right there, and the lateral leaflet is over on the free wall. So this valve has insertions, onto the septum and is divided at this point. If we look from the right side over here, this is the superior leaflet, this is the inferior leaflet here. Here's the free edge of the septum. Here you can see the superior leaflet coming across here. This is the outflow. And you see how this is the left side, this is the right side. There's a division of the superior leaflet here with attachments, albeit sparse ones, onto the crest of the septum. And the inferior leaflet is seen down here. So this is a typical type A. This is a type B. Here we see the aorta here, pulmonary artery over here. These are normally related great arteries in this case. And we'll look into the right atrium here. Here's the area of the fossa ovalis, and here's the edge of the septum, coronary sinus, and the defect is below the level of this. As we open there's the up into the superior vena cava. As we open the right ventricle here, we'll see the superior leaflet here coming across from the other side. There's the crest of the septum. And notice that it continues to the free wall, but it has an attachment here onto a large papillary muscle here, paraseptal papillary muscle right here. And there's a division of the superior leaflet with attachments onto this paraseptal papillary muscle. So this is typical for a type B canal with a large paraseptal papillary muscle and division of the superior leaflet over the right ventricle instead of over the crest of the interventricular septum. If we look at this from the left ventricular side, you again see the superior and inferior leaflet components of the valve. See the scooped out part of the septum here, apical trabeculations and a smooth basal part. And here's the superior leaflet, which continues with the aortic valve, and the inferior leaflet here. And these go to free wall papillary muscles. So finally, we'll look at a type C canal. And in this case, well, maybe we will. I just looked at it a minute ago. Oh well. Type C looks a lot like a type B, only it doesn't have the papillary muscle. Here's the valve from above. This is an unbalanced canal. And look at what I'm talking about here as far as having a common inlet. You can see the real annulus of the valve is up at this level. This is the right atrial appendage here, left atrial appendage here. We've moved the atrial septum, what's left of it, out of the way. And you can see that it's like a pair of pants. The waist of the pants is here at the annulus of the valve, and then there are two legs, one into each ventricle. And so that the difference between a common AV canal and an ASD primum is that there are legs, whereas in a common AV canal it's a skirt. and it just continues down into both ventricles without being divided. In this case, this valve is a little bit unbalanced. You can see that the right ventricle here is a little bit smaller than the left. The plane of the interventricular septum is right here. There's a small right AV component and a large left AV component in this case. There you can see the appendages. And there's the plane of division of this. So you can have unbalance of the AV canal so that it favors one ventricle more than the other. And I think I'll stop at this point and have Norman show you the rest of the anatomy with echo.
Thank you, Steve. I think it's very interesting that we get a little obsessed with the Rastelli classification. Giancarlo is the original Parmigiani, you know. He's from Parma in Italy. And he worked in the Mayo Clinic at the time where it was very critical what kind of complete canal you had, how the surgeon would repair it. Because philosophically, if you've got to divide one leaflet into two, do you put the patch in and then one patch and then divide the valve, or do you put in two patches and leave the valve intact? Now, in the old days, type A and type B and type C, the valve doesn't attach to the septum. So in order to put the patch on the septum, you would have to put in a patch in the ventricular septum and then another patch in the atrial septum. And that's really the surgical problem about why it's so important. Today, the expertise of the surgeons at fixing that makes it less important to understand it, because they can divide the valve, cheat the valve, cut through the valve, put in a single patch, fix it that way. Depends on the preference of the surgeon as to what they want to do. So I think that when you think about when Giancarlo Rastelli was working on this in the 1960s and 1970s, it really did make a difference. But now, I think for the surgeons it makes very little difference. And most really good surgeons don't care about Rastelli classification anymore. So, here we go. Looks good. Right orientation. So, I'm just going to highlight a little bit of what Stephen said. And he talked about what happened there. What happened here is when we look at an AV canal, and we see the scooped outside from the left side, that one of the features of an AV canal is that the inlet is what's mainly scooped out. And that makes the gooseneck deformity, and it also makes the fact that the outlet is long, and why the aortic valve doesn't sit in between the AV junction, but it is sprung out of the AV junction. And it also explains, in fact, the left anterior hemiblock. Because, as Dr. Van Praag said, is you know where the conducting tissue is coming from and you know where it's going to, so you can always trace the course. And in actual fact, the left anterior bundle of the left bundle of the heart has to come backwards and down there. And so that gives the pattern of left anterior hemiblock without actually being left anterior hemiblock. And it also probably gives rise to the counterclockwise vector that is seen on the first phase of the image. So here's just a difference between the normal the normal heart, where the inlet and the outlet are of the same proportions, and in an AV canal where the outlet is actually elongated because it doesn't come and sit in between the two valve orifices, because really in almost all of the complete AV canals or ostium primum, one of the unifying features is a common arteriovenous junction. There's no two separate junctions. There's always one, even if there's an ostium primum ASD. So that's really the feature there, and you can see several different hearts that way, and I think this does move. And here is a subcostal coronal view. Here is the aorta, This is the arch up here, which gives rise to the so-called gooseneck. And the anterior bridging leaflet is attached over here, whereas the normal mitral valve is attached here. And that gives rise to the so-called gooseneck deformity, which we'll see a little bit later. So here's my concept of what a sketch would look like of an AV canal. In the normal heart, the aorta is situated and wedged beautifully between the two atrioventricular valves. Here's the mitral and the tricuspid valve. But in an AV canal, of course, this never happens, so the left ventricular outflow tract is elongated, and here's the canal, just as I think Dr. Sanders showed so beautifully in that example. Now also, because the papillary muscles of the ventricle support the commissures of the valve, if the commissures are in a different position, the papillary muscles will be in a different position, and largely it's the rotation of the anterior one more caudally. The posterior papillary muscle rotates as well, and very frequently the posterior the posterior or mural leaflet of the valve is somewhat hyperplastic. And that's very important in terms of the prognosis for the surgeon, because I think AV canals is the most difficult lesion for surgeons to fix, because they can't create something out of nothing. And when it's deficient, it's really deficient, and it's not simply closing a patch or joining up two tubes together. So, in the development of an AV canal, let's just think of this in embryological terms. You can get communications at the atrial level, where the valve then makes a junction with the crest of the septum, and you get the so-called ostium primum ASD, or you have a complete canal with shunting above and below, or you can get the lesion we talked about in VSDs, the VSD of an AV canal type, where the common arterial junction makes a join with the atrial septum, and you only have a ventricular septal defect. Now here's Rastelli, just looking at it as if you were looking at pathological specimens. And as you remember, the type A of Rastelli is a divided septally attached anterior leaflet. What Rastelli said about the mural leaflets is they're very common and almost unchanged whatever kind of AV canal defect you see. And that leaflet is always attached on both sides with caudal attachment to the posterior part of the ventricular septum. It's the anterior leaflet which is variable. And in type A, the papillary muscle is here, septally attached. In type B, it's attached to the muscle of the right ventricle, as Dr. Sanders showed so beautifully. And in type C, it's attached over this way. So, in other words, this anterior papillary muscle migrates to this position from type A to type C, or invariably, if we will look at this developmentally from an embryological point of view, the most primitive canal is like this, and then it would migrate to have almost no papillary muscle attachment with the normal mitral valve as the AV canal closes. So now we can see this echocardiographically, and this is a type A AV septal defect. You can see here this very easily seen. On the en-face view, which is a subcostal view, we're looking at the RV outflow tract here and the LV here, so we've rotated around a little bit counterclockwise in the subcostal plane. And we see the whole leaflet. Here is the posterior bridging leaflet attached to the crest of the septum, the anterior bridging leaflet attached anteriorly, just as we see here, and we have a type A of Rastelli. And here is a type C of Rastelli. Hey, come back. There is a type C of Rastelli. Oh, another type A. Is it? Yeah. It's attached to the crest of the septum. Another type A. This is what a type C would look like if I had put the right picture there. So we'll look at this one here. Here is a type A of Rastelli again. Same thing again. And here you see the arrows indicating the attachment to the papillary muscles or the ventricular septum. And here is a type C of Rastelli. Now, in the alphanumeric calculation, the first one he saw was a type A, and he called them all type A. And type B was the next one that he saw, and type C was the third one. But there's a nice little point for you can get and score with your surgeons when you see them, is almost all VSDs that are AV canals that are conoventricular, that have a double outlet right ventricle, or a truncus, or a tetralogy, are almost invariably type C AV canals. So when you see a tetralogy and you see an AV canal with it, without even looking for the morphology as we show it here, you can call it a type C AV canal. And here is an overriding great artery, and here is the anterior bridging leaflet, which is free of attachments to the underlying anterior part of the septum or the outlet septum. So type C, whether you like the classification or not, there it is. Now, the valve regurgitation, and Girish, thank you for bringing that point up in VSDs, is fascinating because it's the fundamental of repairing an AV canal for the surgeons is how do I fix the left component of the valve. The VSD they usually can close. The ASD they almost always close. It's the AV valve that determines the outcome of these conditions. And here you see three groups of valvular regurgitation. You see a left component, you see a central component, and you see a right component. Now we have to just discuss a little bit about rheology, which is the science of flow. And there's a number of things that are happening here in an AV canal and in an ASD anyway. There's blood flowing from the left atrium to the right atrium. And what that generally does is it entrains, or it brings the mass of the blood into the direction of flow. So instead of the blood flowing straight up between the left ventricle and the left atrium, it's entrained by the shunt that comes across and moves it to the right side. So this looks like an LVRA shunt. Now an LVRA shunt, besides what Dr. Shirali mentioned about the pressure gradient, is important because if a shunt is going between the left ventricle and the right atrium, and the surgeon bands the pulmonary artery, he does nothing to the left ventricular right atrial shunt, unless it's an entrained shunt. And my mentor, Dr. Abe Rudolph, who mentioned that, always called this what he called an obligatory shunt, like a shunt in an arteriovenous malformation, like a sacrococcygeal teratoma or a vena Galen malformation. It doesn't matter what happens to pulmonary vascular resistance under that circumstance, the shunt stays the same. So those are much more malicious. And yet many AV canals have been banded, probably because the left ventricular right atrial shunt in this circumstance relates to the entrainment that is occurring in the left atrium. And in the fetus, for example, where you see a right to left atrial shunt because of the difference in the circulation, the shunt goes from the right ventricle to the left atrium. So that sort of enforces the entrainment philosophy about that shunt. So here you see multiple levels of shunt. You see a secundum defect, a primum defect, which you can see on the picture, and you see the caudal attachment going through the very large ventricular septal defect in this case. Here's the three shunts I was mentioning. You know, the one on the left side here, this one here, probably is occurring at the junction between the mural and the posterior leaflet. That's one of the critical areas. This one is coming through the cleft in the valve, and this one is coming from the right side. And as you can see, they all seem to be moving in one direction towards the right atrium. And there is a beautiful example of a LVRA shunt. And of course, if you take the pressure on that atrium and you think you're dealing with tricuspid regurg, you're liable to get a systemic level or even higher, because left atrial pressure is generally a little lower than right atrial pressure. Okay, so here you see what happens in AV canal defects. When you start off with a bad valve, it's going to affect your prognosis. So complete AV canal, type unspecified, and I'll explain that in a moment, but with a big left ventricular to left atrial shunt and a smaller left ventricular to right atrial shunt, and this one is probably arising at the cleft in the valve. Okay, and there you see a whole series of different ones, and this one clearly looks like a more normal mitral valve. This is coming from usually from the junction of the mural with the posterior inferior bridging leaflet. Now this is the fetus that I saw, that is a neonate now, that had such severe left ventricular outflow tract obstruction that even though this was an AV canal, a complete AV canal, it presented with signs of hyperplastic left heart because the left ventricular outflow tract was totally blocked. Now, this is just a little point about the partial AV canal or the intermediate type AV canal. In that kind of condition, this was described by the Japanese in about 1974. They called this the tricuspid pouch lesion. But you see this outpouching of the atrioventricular valvular mechanism into the right ventricle. There's a little shunt below, and there's a little shunt. So this classifies as a partial or an incomplete AV canal, as Dr. Sanders has described, which is, I think, very valuable. Now, the mitral valve cleft is not actually a cleft. It's probably the wrong name. It's really a commissure, and it's a commissure between the primitive anterior superior and posterior inferior bridging leaflets. And the commissure would normally go to the crest of the ventricular septum or through the ventricular septal defect, and it almost always points towards the right atrium rather than the right ventricle. The papillary muscles, as I said, can get very close together. This is a patient who had a single papillary muscle, who had the papillary muscle split as part of a repair, which didn't work very well. We'll see the rest of his pictures a little later. And this is a beautiful example of a highlighted parachute mitral valve. Here's another one from my connection as part of a Schoen's complex. So the papillary muscle position is very important. As Dr. Sanders had mentioned, you know, that the atrial septum pretty much looks like a regular atrial septum. What's happened is that the valve has not made a connection with the underside of the ventricle. And you can see that type of pattern there with the secundum Vsd. Here is a tetralogy AV canal. This is going to be a type C AV canal. Here's the anterior bridging leaflet going through the Vsd. Here's the overriding aorta just above it. When you look on the right side, you see the ostium secundum atrial septal defect, a large ostium primum defect, and a type C AV canal defect. And we can see this on the echo. Here we're looking at the inlet portion in the subcostal sagittal plane, and you see the valve leaflet going right through the ventricular septal defect. But when you look at the outflow part of the ventricle, it looks like a classical tetralogy of Fallot. So inlet looks like an AV canal, outlet looks like tetralogy of Fallot. Now, let's just talk a little bit about dominance, because I think that's very important. So there comes a point in time when you've got a complete AV canal where you have to decide, can I do a two-ventricle repair over here? And we're going to have a section of this after, is it after lunch today? No, tomorrow, where we'll be talking about this lesion as part of that particular entity. And we call this dominant. So whether this valve, as you can see here, is really right dominant to this part of the AV canal here. And that's a right dominant AV canal, and perhaps sometimes, depending upon various phenomenon, we can repair that lesion as a two-ventricle repair. Otherwise, it has to be repaired as a single-ventricle repair. And here you can see a right dominant AV valve with massive regurgitation, even of the right component of the valve, with this Coanda effect, hugging the base of the AV valve and heading straight into the right atrium, and the long axis equivalent from the same patient over here. Here's a left dominant AV canal, and you can see here the right ventricle is over here. This is all left ventricle on this side, and the canal is unbalanced almost exclusively, as I've drawn on this cartoon, to the left component of the AV valve, so left dominant AV canal. Here's this little junior right ventricle here. Here's the common bridging leaflet straddling the whole ventricular mass, but as you can see, it's draining exclusively here. Patient's also got a small pericardial effusion. Now, one of the things about dominance is that when we look at dominance like this, and we did some work on this, that shows here that when the septum is pushed back, you may have an erroneous idea of the balance. And when you fix it and the pressure in the right ventricle falls and the pressure in the left ventricle rises, the septum may become spherical. So we did a study looking at this, and we looked at right and left ventriculus for balance to see whether these valves could actually be fixed. And we found, in fact, that we did a whole series of things, but essentially we calculated what the ventricular volume would be if the septum had changed the other direction. We got to a very close approximation, but not quite, because we didn't make an allowance for an increase in left ventricular length. Otherwise it would have been perfect. So again, you have to have in your mind a three-dimensional concept of how ventricles change and mark for your strain and everything. It's not just in one dimension, it's in all three dimensions at the same time that occurs. So Dr. Merrill Cohen, on the other hand, looked at dominance and balance and measured the plane limited the left atrioventricular valvular component and the right atrioventricular valvular component, and found when this was less than a third, then the whole orifice, that this was likely to end up being a one ventricle repair. I'm not sure that we agree with her data. So the summary of balance is a very complex issue. Treatment is based on morphological factors, direct and indirect surgical preference, and philosophy of whether you think a one ventricle repair is worse than a two ventricle repair in terms of the patient's ultimate prognosis, not what you think about one or two ventricle repair. And echocardiography can provide many of these determinants. Unfortunately, as we always have to say in ultrasound, the surgeon has the final decision. So let me just quickly talk a little bit about post-operative findings. And the most important thing in post-operative findings, as I already alluded to, is how well has the surgeon repaired the left component of the AV valve. And in fact, not only repaired it, but maybe even damaged it. Because there's really a lot of subtleties about how to fix this that we've learned from three-dimensional echocardiography that Dr. Jeff Smallhorn in Canada has pioneered, about what the valve looks like and how you have to fix the valve and how you can calculate the strain and the seating of the valve, which is really very subtle. I don't know whether Girish has got anything. You don't have anything on that. It's really quite brilliant work. And I think what is happening now that's interesting about echocardiography is that looking at this data is providing the surgeons with an education on how better to repair these valves. And I think that's very important. So here is really the bottom line. Sometimes the surgeons really realize that they're going to have to eventually go to a prosthetic valve in these situations. But in small children, it's probably better to deal with a milder or moderate degree of AV valve regurg before you replace the valve. So I think it's very important. And then you can see here, even in this patient who's had an annuloplasty, look how small the valve is and is stenotic, has still got a substantial amount of leak coming out of that valve. I'm not really a great fan of believing that the directionality of the jet tells you exactly where the defect is occurring. I don't know whether anybody feels any differently. Here's a patient who's had an annuloplasty done in a surgical technique. You can see very beautifully the sutures, the rhythmic nature of the 1 millimeter sutures of the annuloplasty that the surgeon has put in on this valve, which unfortunately, let's leave that one, broke down and the patient needed another surgery. And of course, residual VSDs are another problem, which I just had over here, which I don't think is very exciting or any different. We can tell that this one is occurring at the upper end of the patch. There was also another one down here. The surgeons have to be very ginger about applying the patch here, because one thing we know is that the conducting tissue is running right on the crest of the septum. So the surgeons have to place their patch on the right side of the septum to repair these valves. Well, we're running out of time, and I thank you very much. I don't know, is there somebody else that's talking? Girish?
I mean, I can talk after lunch.
No, we're going to finish this before lunch, so if you've got 3D stuff, this is the time we want to do it.
Could you drop the lights, please? All right. So I've already showed you the normal. Apical four-chamber view and how to crop that, and I've already shown you a normal mitral valve. So I'm not going to go back to those. I'm just going to quickly show you a couple of examples of the way that things look by 3D. This is one of my most favorite images of a cleft mitral valve, and basically, to start, I can show you what these look like by 2D echo. They kind of look like something like that, and this is what they look like with in 3 dimensions. So here you see this. This is the left lateral, or the what Bob Anderson calls the mural leaflet. This year he calls it mural. I don't know what he's going to call it next year. I know. Next year will be different. Then there's another leaflet here and another leaflet here, or what Richard Van Praag would call this is a mitral valve that is cleft with with one part here and another part there. Bob Anderson will call this the left component of a common AV valve. I'm just going to put both of those nomenclatures out there. This is not somebody who has a large VSD, so just for you to know. The useful thing about this is that you can actually look at it from above, which is kind of nice because that's the way the surgeon looks at it. So our echo views are all upside down kind of views actually, and so this is the pathologist or the surgeon's view. So when he cuts off the roof of the left atrium, that's really what he's going to see, and that's what he's going to end up. That thing is there, whatever you call it, cleft, commissural region of apposition, zone of apposition, call it what you want. That's where the stitches are going to go. So that was the cleft. Then I think I showed you this one already. The concept of the scooping out of the ventricular septum that you see with the common AV valve, with the canal. So that's the inferior and the superior bridging leaflet. So sort of similar to what Dr. Sanders was talking about. So if you take a look here, you'll see that this AV valve, this is a type C. It has no attachments to the crest. So we're looking with the type Rastelli type. We're looking at the attachments of this to this crest of the ventricular septum. But this one has very, very few caudal attachments to the crest of the ventricular septum. So there is an enormous potential for shunting at the ventricular level. And then this other concept of inlet to outlet disproportion. And then looking at the same thing from the right side. So one of the interesting things about complete canals is that usually the VSD tends to be larger below the superior bridging leaflet and smaller below the inferior bridging. We've seen situations where there was a VSD only below the superior, not below the inferior, and vice versa. This one is interesting because it's big below both, but you can see that it's much bigger below the superior bridging leaflet than it is below the inferior bridging leaflet. And then the same view, so same heart, same specimen, some other things that I think are well shown by 3D imaging. So the concept with 3D becomes far more of an en face view kind of a concept. Look at the ventricular septum en face, and look at the common AV valve en face as well. So now here we are, we're looking at the common AV valve from above. This is the patient's right side, that's the patient's left side, left lateral leaflet here, right lateral here, inferior bridging and superior bridging. And see the stuff that comes up here, this prominent knobby thing, like broccoli. It's a common AV valve that is redundant. It's prolapsing into this part here, it's prolapsing. So these are prolapsing rightward and central scallop of the common AV valve, superior bridging leaflet. So this is a very useful way to be able to, if you put color on this and if it was leaking, a good way to be able to tell your surgeons exactly where the substrate comes from. And here the aorta is out over here. When the valve opens, you see this thing that's blue. This is a three-dimensional image with a holographic map, holographic viewing map, grayscale map. And so structures that are far away from the screen, far that way, are going to look blue. And that blue thing that you're seeing, what do you think that is when the valve opens? It's a ventricular septum. It's a ventricular septum, okay? So that thing there is the ventricular septum. Right? And you can look at the same thing from below. So the concept then of views becomes very altered, because you can actually get, you know, in the right patient, of course, you know, they have to have windows. But see, this is a full volume acquisition from an apical 4-chamber view, and this is the equivalent of a subcostal view showing you the superior, left, inferior, and right leaflets of the common AV valve, and the aorta over there. That's the aorta up there. This is another example of a cleft right there. And what you do with these 3D images that's very different from 2D is you can actually move them around to look. So now we're looking up at the aortic outflow tract over there, and now we're looking up at the pulmonary outflow over there. It's just a different, you know, you just get used to doing different things. On the machine, you move the trackball to rotate these pictures around. And I think it's a different mental construct. It's very similar to what the surgeon does or what the pathologist does. It's not very similar to what 2D echo people do. So that's really one of the big differences. I'll show you two other examples. This one is sort of the partial form of the defect, the Primum ASD, like that. Right? Now, if you remember what Dr. Sanders talked about in terms of the shape of this defect, the shape of this ASD, that it is a crescent-shaped ASD. Right? Remember, everybody remember this? Jacob's definition from 2000. So the idea is, let's try and find out what this defect looks like by echocardiography. Because by 2D, you can only really tell with this image that it looks like this. You would have to sweep and then build that in your mind in terms of what it looks like. So here now we'll do the same thing with 3D imaging, and that's your crescent right there. So that's a crescentic edge of the atrial septum. Below it are the AV valve leaflets. So this is the right-sided leaflets over here. And then if you look from the left side, you'll see the left-sided leaflets. And the idea being that because the bottom of the defect is AV valve tissue, that's why these patients cannot have device closure of their ASD. It would really give you very bad results. Now this data set actually demonstrates something that Dr. Sanders was talking about. Remember the previous one where we saw a complete canal, where we saw this big hole? When we looked from the side, we saw big ASD and a big VSD and bridging leaflets, right? And the crest of the ventricular septum was scooped out. So look at it over here. See this? You see that line? That C shape. So that's the crest of the ventricular septum. This is the edge of the atrial septum. And basically what we are seeing here is these are caudal structures that have pretty much come through and fused to the crest of the ventricular septum, so that there is no ventricular level shunting. Yes? So if you cut away this thing even more, you'll probably be able to not tell the difference between this and a complete type of defect. Okay, the last one I'm going to show you is an interesting patient who has so basically this person has dilated right heart, common AV valve, no offset, right? All of that looks pretty clear. One orifice, another orifice, and a big VSD over here. And so now once again we'll do our cutting and see what we get here. So what you see is edge of the atrial septum there. This is a tongue of tissue. This is in the plane of the septal structure. So the superior and inferior bridging leaflets of this canal have fused in the middle. They fused in the middle, but they've left a big VSD below. You see? So this is a rare type of a defect because the defect, if the VSD is large, it's not the conventional sort of what we think of with the transitional canal is we think of a restrictive VSD, small VSD. This is a big VSD. It looks very similar to the previous ones that we showed. But the difference here is that you've got a big VSD with two orifices. In fact, the VSD here is much larger than the ASD is. And here we are looking at it from the left side. So again, crest of the edge of the atrial septum, very elongated, sort of slit-like ASD, large VSD. Yeah. Sure.
In Av Canal patients, left parts of the heart are sometimes so diminished in the side by huge right parts.
Yes.
Sometimes it's very difficult to distinguish if they are hypoplastic left heart syndrome or
Yeah.
the physiology.
Exactly.
How can it be distinguished by
Yeah. Yeah, I think we use a variety of different different things to try to figure that out, and I don't think that everybody that that we know the final truth on this, but I think there are many different variables. I think what Dr. Silverman talked about and what you talked about is the septal structures bowing over. There are many other things. For example, how big are the lateral leaflets? That's a very useful sort of indicator. What is the nature of the papillary muscle structure on the left side? So if you have only one papillary muscle on the left side, then when the surgeon goes in to completely close the canal and close the cleft, then what they will end up doing is they will end up creating a parachute left AV valve, which means that maybe, so they have to be ready for that post-operative problem, which you're talking about probably a stenotic left AV valve. Or they have to say, I'm not going to close the cleft, leave the cleft open, which they will agree to do. They have to do many times when you've got a small left side. So the rule that Dr. Silverman talked about, where you look at the common AV valve and you planimeter it, and you imagine where the plane of the ventricular septum should be, and you get a 2/3, 1/3 kind of a, if it's more equal than 2/3, 1/3, then that is more favorable towards biventricular repair. I think it's a difficult rule because whenever I have a problem with the heart and I'm trying to answer it and I do the planimetry, it's exactly 2/3, 1/3. So it doesn't help me at all. So we use a lot of these other things to try to answer that. You see what others have to say. Steve, Norman.
So I think we have to be out of here. So and everybody's probably ready for lunch. So I'm going to show you guys just one quick example and then show you how we, some of the 3D reconstruction. And so this is actually an unbalanced AV canal. This is a 12-year-old that had unbalanced AV canal, hypoplastic left ventricle, and underwent a Fontan. But I want to show you guys, you can see the AV valve very nicely here. You can, oops, sorry. You can see the prolapsing of the right-sided AV valve and the abnormality. This patient actually also had a dilated aortic root from the Fontan procedure. You can see the aortic valve, the abnormality. But what I wanted to really show you guys is this is the 3D reconstruction, and what I want to show you is how we, oops. And so, 1 second. And so this is the navigator that I was telling you guys about. It leaves a shadow over here. But then if you go into 3D reconstruction of this patient, you're going to be able to see all three axes, and you can move this anywhere you want. You can move this in a 3D reconstruction. You can see here the fontan of the patient, IVC connecting very nicely. You're also seeing the small aorta, the native aorta. You can see the neo-aorta and how dilated it is. As you go through the image planes, you can also see right here, you can see the coronary arteries. I'm going to enlarge that for you guys to be able to see that a little better. And here are the coronary arteries coming off of the native aorta. You can see the very dilated neo-aorta, or what used to be a pulmonary artery. And as you go through this, you can also see the branch pulmonary arteries, the descending aorta, and you can change the planes that you look at these in any way you want. And here's the coronary artery.
Can you show us the left ventricle?
Oh, sure. So here's the coronary artery. I was asked to show the left ventricle. Well, it's a very small left ventricle because it's a hypoplastic. And you can see right here, this is all you've got of your left ventricle. I can bring this over. And there's your small left ventricle right here that you can see, and the big right ventricle. So I just wanted to show you guys this because I think this is very nice way, very similar to the 3D reconstruction that you get in echo, but you can get this by MRI and show all the different images and be able to see through that. And I'll show more of these with more complex anatomy so you can get an idea of it, but I just wanted to start with